Thank you. Good evening, everyone. As Dr. Jailan said, my background is in interventional cardiology, and a lot of the techniques that we employ in CRT implantation come with a bit of bias from that side. But then it's good we have other colleagues who will guide us on what else they do, and we'll have an open discussion on that. So I'll very quickly go through the steps of implanting the CS lead or the LV lead, and take us through some common pitfalls that occur during the procedure. I'm just having a bit of challenge in moving my slides. They don't seem to be moving. Just give me a minute, please. Get my pointer here. Excellent. So essentially the steps of CRT implant procedure, we obviously start with venous access, which is very similar to the venous access we use for implanting a pacemaker or an ICD. What is peculiar now is that we go on and do the coronary sinus cannulation, and we'll spend a bit of time talking about that. Once we have cannulated the coronary sinus using various methods and technology, then we want to know the anatomy of the coronary sinus, and at that point we do a venogram using contrast. That tells us where we can position our left ventricular lead optimally. Once we do that, we obviously then advance our lead into the branch which we have selected. And then we do some testing of the LV lead, paying particular attention to phrenic nerve stimulation. And finally, we remove the tools that we use to deliver the LV lead, so that we can secure it into place. So venous access, very similar, and everyone has their own techniques of getting venous access. But ideally, an LV lead should have its own venous access site. There's some practice among colleagues where you get one puncture and then you use that one puncture to put in multiple wires. And that is usually discouraged for an LV lead because when you are moving the technology, you can easily displace the other leads. Also, the delivery technology is quite bulky. So ideally, get its own access point, and ideally it should be lateral and away from the RA and RV punctures. Whether you choose to implant the RV lead or the LV lead first has its own advantages and disadvantages. In our practice, we usually implant the RV lead first. First of all, in case the patient has left bundle branch block and you knock off the right bundle branch, so you have backup pacing in place. The second thing is it also gives you an idea of the anatomy and the size of the right atrium, which can help you cannulate the coronary sinus. On the other hand, more experienced implanters sometimes go for the LV lead first, because then there isn't too much technology in while you're trying to cannulate, and potentially it might be faster. However, most people I know would implant the RV lead first. There's a small risk of dislodging the RV and RA lead as you are trying to cannulate the CS, but a lot of the times that can then be repositioned. Let's talk a little bit about anatomy of the CS, because the next step is cannulating the coronary sinus. And the coronary sinus is a structure in the right atrium. It's a posterior structure. And when we look at this view from above, we can see that there is the tricuspid valve, and this is the interatrial septum. So the coronary sinus lies posteriorly in the interatrial septum. And that's important in that the movement you choose, when you're looking from above, you can visualize that your catheter would have to, if it was facing the tricuspid valve, it would have to anti-clockwise rotate to get in. So that's the movement we usually use. And when we look at the coronary sinus from the right lateral side, we can appreciate its relationship with the tricuspid valve. So it lies just a little bit above and posterior to the tricuspid valve. And so this is just important anatomy to appreciate. Now, a little bit of the schematic anatomy of the coronary sinus. So as we said, the coronary sinus arises from the right atrium. And one of the first branches that come out of the coronary sinus main body is the middle cardiac vein. And this is the posterior view. So the middle cardiac vein will run in the posterior interventricular groove. A lot of the times we don't use the middle cardiac vein to implant our leads, but sometimes when you're out of options, we have a lateral branch occasionally that comes out from the middle cardiac vein and goes to the lateral wall of the left ventricle, and we can occasionally utilize that branch. So the main body of the coronary sinus, at the point where there's a structure called the valve of Vuesens, at that point, this now becomes the great cardiac vein that goes towards the lateral aspect of the heart. Now, in between the coronary sinus and the lateral aspect of the heart, there are a variable number of branches that come off. We have various posterior branches, posterolateral branches, and lateral branches. And those are usually the branches that we are targeting when we are looking for ideal anatomy. So this is sort of the region. And then when the great cardiac vein comes to the anterior aspect of the heart, it usually continues into the anterior interventricular groove alongside the LAD. So that's, in short, the anatomy of the coronary sinus. Now, what about fluoroscopic anatomy? So when we talk about fluoroscopic anatomy, we always use two views. We use the RAO view and the LO view. And in the RAO view, you're looking at the heart from the right side. So for those of us who are echo oriented, this would be a long axis view. So in this view now, the coronary sinus, as we know, is running in the AV groove. What is to the left side of the coronary sinus will be the atrium, and what is to the right side of the coronary sinus will be the ventricle. So this view really helps us decide on how apical or basal a particular branch is. So branches that are, or a position that's very close to the coronary sinus is considered a basal position, and a position that's farthest away is considered an apical position. On the other hand, when we use a LAO view, we are looking at the heart as if you're looking at it through the apex into the base. And for echo views, this would be considered a short axis view. So, as we said, the coronary sinus is a posterior structure arising from the right atrium, and it runs laterally towards the lateral border of the heart in the AV groove. And so this is now a good way of determining in the LAO position which veins are anterior, which veins are lateral, and which veins are posterior. So as we said, the first branch that comes off usually is the middle cardiac vein. And as we go more laterally, then we have the posterior vein, the posterolateral veins, and the lateral veins. And then finally, we have the anterior veins. So in short, this is the fluoroscopic anatomy. And this is what it looks like on fluoroscopy. So this is the LAO view, where we're looking from the apex towards the top of the heart. So as we run laterally, come across the middle cardiac vein, the posterior veins, and the posterolateral vein and the lateral vein, and then finally we go anteriorly. So if you're going anti-clockwise, then we're going from posterior to lateral to anterior. On the other hand, this is the RAO view, and the RAO view, as we said, tells us how basal we are, how apical we are in position, and those are important to determine the final position of the lead. So let's move on and talk about cannulating the coronary sinus, and there are various methods of cannulation. There's an anatomic guided cannulation or an electrophysiology guided cannulation. Personally, and in our practice, we use the anatomic cannulation. Using the anatomic cannulation, there are two methods. In the first method, we can just use the standard J wire with a guide catheter. On the other hand, sometimes if that alone doesn't work, then we use assistance of various other coronary wires, what is called the coronary diagnostic catheters, what is called the telescoping techniques. And commonly, we use either an implant catheter or multipurpose catheter. So this is a video, and I hope it projects well, which is showing us using the standard technique where we just have the guide catheter. So this is the guide catheter, and it has a J wire inside it. And the technique is that we uh, advance usually advance the wire into the right ventricle initially, and uh, and once we get into the right ventricle, then we put the guide into the right ventricle. And once we are in that position, then we gently withdraw from the right ventricle with an anti-clockwise twist. And usually at that point, we will get a jump, and the guide usually jumps into the coronary sinus. And when you see that jump, then you can probe with your J-tipped wire to see if you can advance your J-tipped wire into the coronary sinus. Some people will take a puff of contrast at that point, but in our practice, a lot of the times we would do a gentle probe with a J-tip wire. And as long as you have a J-tip and you are being gentle and you understand when to stop probing based on the behavior of the wire and how much the guide backs out, then it's a very safe technique, and we've not had any problems doing that so far. So I'm probably just gonna play it one more time so we can all see. So we can see our wire trying to go into the right ventricle, and now we are at the right ventricle. And usually this coincides with the curve of the RV lead. And from the right ventricle, now you withdraw your wire back, and then you do an anti-clockwise rotation. So this was unsuccessful, but we are close. So again, we try and we change the angle a little bit and do an anti-clockwise rotation. And at this point now, it's looking more promising. And finally, we're able to advance our wire into the coronary sinus. Now, this is the second technique that we use, and maybe the video is not as clear, but again, we have a guide, but inside the guide is an implants-2 diagnostic catheter, an AL2. And using the AL2, we place the AL2 in the right atrium, and we usually do a anti-clockwise rotation. So there's an anti-clockwise rotation being done here, and there will be a jump, and you can see that jump, but that wasn't in. So again, there's more anti-clockwise rotation being done, and there's another jump there. And at that point, the wire is being advanced, and the operator was confident that he was against a valve there, and he pushed, and it eventually went in. And so this is the cannulation of the coronary sinus is usually done in an LAO view. And the reason we do it in an LAO view is that once it crosses the midline or the spine and goes towards the right side of the screen, then we know confidently that we are in the coronary sinus. And at that point, then we can take our venogram. So in cannulation of the coronary sinus, there are various challenges that are encountered. Patients may have a very large right atrium. Patients might have a very prominent Thebesian valve, and there are several anatomic variants which we encounter. So a right atrium which is enlarged is challenging because it doesn't provide the guide with adequate back wall support to advance the wire across the Thebesian valve into the os of the coronary sinus, and that can often lead to difficult cannulation, and there are various ways of overcoming that. The first one, if you're using the just the regular guide to engage, then you can use a larger hook. So there are several hooks available and shapes available on the type of the guide catheter that we can use. Most kits will come with a standard hook and an extended hook. So if the standard hook is not working, then you might have to use an extended hook. And sometimes even that is not adequate. And then in that case, a telescoping technique comes into handy. So you can extend the reach of your hook now by using an Amplatz catheter. And often an Amplatz 2 will do the job. And if that doesn't do the job, then sometimes you might have to use a bigger curve like an Amplatz 3. And that increases your reach so that you can be against the back wall of the right atrium and still reach the coronary sinus. Then occasionally we encounter what is called a very prominent Thebesian valve. The Thebesian valve is essentially a membrane that covers the ostium of the coronary sinus, and you can see that it's posteriorly directed. So what happens is that if you're a lot of the times, if you're coming out of the tricuspid valve and trying to cannulate, it might direct your equipment over the CS os and more posteriorly. And this can happen in various forms. It's usually not a problem. A lot of the times your wire can pass through, but sometimes it can be very prominent, covering most of the os. Occasionally, you can get a cord-like appearance in the middle. Sometimes it can be fenestrated, or you can get a mesh. So all those are the various ways in which it can obstruct your wire. And there are various things you can do to try and overcome that. First of all, your wire a lot of the times will go through, and sometimes you might need to use extra supportive equipment. Something that we call a subselect tool can sometimes be very useful in these instances. Sometimes what happens is that your wire goes through, but you cannot advance your guide catheter through. So in that case, is the inner sheath of the subselect tool, or the dilator of the subselect tool, which is quite atraumatic, can help you overcome that. And this can also be used to help you overcome valves which are inside the coronary sinus, as we shall see. Occasionally, you can get stenosis of the coronary sinus, and this is a picture that just shows branch stenosis, but occasionally you can get main body stenosis. We recently had a patient who we were re-implanting after an explant, and he had a complete occlusion of the coronary sinus body, and we had to look for other branches to implant it. So how we overcome that is, first of all, we can try and use special wires. So if the standard J wire is not going through, then we can use a wire with a smaller curve. And sometimes we may also need to use a coronary wire. Again, a lot of the times, the subselect tools inner dilator is very useful in these instances, and it can help you sort of gently dilate your way through. And if that doesn't work, then occasionally you might have to perform a venoplasty, as is the case over here, using various sizes of balloons. Right. These are some pictures of the subselect tool that can often help us. They are designed to access difficult side branches, but they can often help us pass through valves and stenosis, especially the inner dilator, which is quite atraumatic. Right. So moving on to choose the correct lead for the correct vein. The next step, once you've cannulated the coronary sinus, is to do a venogram. And a venogram allows us to visualize the anatomy very well. We have to be careful in patients who have renal dysfunction, and we have to also be, conservative in how much we use. A lot of the times we do venograms using what is called an occlusion balloon. And I'll show you a difference between a venogram done with and without the balloon. Because remember, as you inject your blood into the coronary sinus, as opposed to coronary angiogram, the direction of blood flow is against the injection of your contrast. So when you inject your contrast, a lot of it is going to be washed out immediately, and you are not able to visualize the distal the distal veins. A lot of the times the target veins are quite distal. So what happens is that we advance this catheter, which has a balloon at the end. One thing we have to be very careful when we are advancing this balloon is to not advance it into a small vein. And there's usually the vein of Marshall that uh, comes off the main body of the coronary sinus, which is directed towards superiorly towards the atrium. And if this catheter goes into that vein and we end up inflating, it can have some disastrous consequences. So the best way to advance this catheter is to advance it all to the tip of your guide and then fix it in position and withdraw the guide. So sort of desheath it rather than to advance it. And that's a safe way because that means you're not going into unknown territory. So once your balloon is in the coronary sinus body, then you inflate it. Usually it comes with a syringe and you just inflate it with air, and you can usually see it once it's inflated. And once you do the inflation, then you can inject. And you can see that I'm playing right now a video of an angiogram which was done without balloon. Having some challenges playing the videos. So I'm just going to go back and then come. Yeah, so this is an angiogram of a video done of an angio of a venogram done without a balloon. And now, in contrast, on the right side here, having challenges again.
It's because
Yeah.
you've used the pointer. Yeah.
There you
There
go.
you go.
Right. So now you can see the venogram, which is done with a occlusion balloon. So our balloon is inflated here. And this is a very nice venogram. You can see that our balloon is inflated, and this allows the distal vessels to fill. And then right at the end, we deflate the balloon. And this is actually the right way of doing it. Right at the end, you deflate the balloon. And as the balloon deflates, the rush of contrast outwards also fills the proximal veins, and you can adequately visualize them. So a lot of the time, this is not done, and you miss the proximal veins. Right. So this is the standard, and ideally, you should do the venogram in two views, both the LAO view and either a PA or an RAO view, so you can see the different aspects of the anatomy. Some things we need to keep in mind is that obviously do not place the balloon too deeply into the coronary sinus because you also want visibility of the proximal branches as we discussed. And then be careful, do not overinflate because there's risk of causing damage to the coronary sinuses. So what views do we use? When we use the AP view, the standard AP view, usually the spine is to the left of the heart. And this is a good view also to tell us how proximal or distal, or rather how basal or apical a vein is. But a better view would be an RAO view. So the RAO view elongates the heart such that the atrium is to the left and the ventricle is to the right. And that tells us how distal we are. So in most literature, the ideal position for placement of a lead would be a non-apical position, so either basal or mid cavity. And when we do the LAO view, this again tells us how posterior or lateral or anterior we are. And that again helps us decide our vein of choice. And an ideal location again for this purpose is a vein which is either posterolateral or lateral. So posterolateral or lateral position from basal to mid cavity is an ideal position. So when we do our two views, now we can have a 3D understanding of the cardiac anatomy. And this helps us now divide the heart into a basal, mid, and apical position. And from the LAO, again, as we talked about, we have this anti-clockwise rotation that goes all the way from 6 o'clock to 12 o'clock, from posterior all the way to anterior. And the ideal location, as we said, is a basal to mid position in a posterolateral or a lateral position. right? So this sort of is a nice diagram to tell us where we should be. We can think of it again as a clock face. So in a clock face, ideally we should be between 4 o'clock to 6 o'clock position, as we said, yeah, posterolateral to lateral position. So what are some anatomic challenges now once you are inside the coronary sinus? So we have various valves which we can encounter. Sometimes we have different ostia of certain branches, and we can have very tortuous veins. So the Vieuxens valve often becomes uh, a challenge when it is very prominent, and it prevents us from advancing our equipment. So the lead or the guiding catheter, sometimes we can't advance them through. And there are various ways, again, of overcoming that. As I mentioned earlier, we can use the dilator of the subselect tool, and that can sometimes poke through. Sometimes a wire will go through. So if the J-tip wire doesn't go through, then another wire, like a coronary wire, might advance through. And you can use that to track your guide across. Um, then often we can have uh, these ostium that come off very early. So sometimes we need to use the middle cardiac vein. And often if there are no good branches, we'll use a lateral branch of the middle cardiac vein. And sometimes what happens is that the middle cardiac vein comes off quite early. It comes off even before the os of the CS, or sometimes just very immediately after the os of the CS. And that can become a challenge because, first of all, we can't visualize it well when we are doing our venograms. And secondly, taking our equipment in can become a big challenge. And so in this case, again, the lifesaver is the subselect tool, and that can help you cannulate selectively the branch and also do a venogram selectively. And I have a video of that, which we recently used this technique. So we can see here that we are doing our venogram. And very earlier on, we couldn't find any branches which were distal. So very earlier on, we can see the middle cardiac vein just appearing there, but not really opacifying well. So we tried to do a balloon venogram, but our catheter kept falling out because obviously this branch is too proximal. So then what we did is we took a subselect tool. Just pause this. And using our subselect tool, you can see that now this is a 130 subselect tool. With a gentle clockwise rotation, we were able to get into the middle cardiac vein. And then obviously we are not yet coaxial, but then eventually we became coaxial and we are able to do a good venogram. Unfortunately, there was no good target vein there, so we found another target vein. And then finally, you can occasionally encounter tortuous veins and very small caliber veins. Sometimes you can have a very acute or a very angulated takeoff of one of the side branches, and just advancing your coronary wire might not be enough. So that's again where I'm sorry I've been talking about subselect tools, but usually they save you, and you end up completing a case which you otherwise would not have completed. So subselect catheters will help you get into the side branches. And sometimes coronary wire with the right kind of curve at the tip, you can get into all sorts of anatomy, and then over the wire you can advance your lead. And then finally, the next thing we need to talk about is the appropriate lead selection. So based on the size of the vein, based on the tortuosity of the anatomy, we decide on which lead shape that we can choose. This is just pictures of one of the company's leads, but the concepts are similar. So we have different sorts of leads, and when we talk about the quadripolar leads, we have generally the 4598 and 4298, the choice between the two in most cases these days. And what helps you decide is how large the vein is and how tortuous the vein is. So if you have a large vein, the problem is stability. A large vein is easy to get into, but your catheter will not stay there, and often it will prolapse out. And so in that case, you want a catheter which has a very stable shape. And what will happen is that these catheters, when they're on the wire, they assume a straight shape. But once you remove the wire or you remove the dilator, then they assume their natural shape and they hug the walls of the vein, thereby stabilizing them. On the other hand, if you have very small and tortuous veins, then sometimes you might need to use the leads without any shape. And this is the only way you might be able to get them down. So a lot of this depends on you doing a good quality venogram in different views, and that helps you also decide on your lead selection. One common problem that happens with CS lead is phrenic nerve stimulation, and this manifests as a twitching of the diaphragm. So usually after we implant, we do a test at high voltage, 5 to 10 volts, and patients might get a diaphragmatic twitch. So again, as we say, try and implant the lead tip 2 to 3 o'clock, and we do the tests obviously during the implant because you don't want surprises later on. And if you do find that there is a twitch, then you can slightly reposition. You can either retract or advance a little bit and see if the twitch goes away, or you can change the configuration. And these days, a lot of the times we use the quadripolar leads. And with the quadripolar leads, you have multiple options of polarity that you can experiment with. And usually you'll find one that doesn't lead to diaphragmatic twitch. And then the final step is removing your equipment, and basically you want to remove your splittable guide. So there are different kinds of splitters available out there, and the concept is that the splitter will fix the lead in place as you pull out the catheter. So it's important that before you do this, you are familiar with the mechanism. There are different mechanisms. In one type of slitter, you hold the lead between your thumb and the slitter, and in the other type of mechanism, you actually lock the lead with a locking mechanism, and you don't press anything. So it's very important to be familiar with both. And I think with that, Dr. Jaylan, it's probably just my overview here, and I'll hand over back to you.
Thanks for that. That was really thorough and well explained. And we have Muzahir. I don't know if Muzahir wants to join and share some sort of some of his own experience and insights into this. Can I ask the host, whoever the host is, to pin Muzahir onto the
I'm here.
Onto the space, and
can you hear me?
Hasham, we can hear you, yes.
Okay, cool.
But we can't see you. I don't know who's pinning the videos, but if we can get you
we
pinned...
can see him, Dr. Jaylan.
Oh, okay, fine.
He's pinned now, yeah.
So let me just I'll pin him. I think we may have to pin him individually, according to the view setup that we have on our Zoom. So I'll go with speaker. Go ahead, Muzahir. Muzahir is an electrophysiologist in Leeds, and one of the senior African Heart Rhythm Association council members. An excellent teacher. Muzahir, tell us, would you like to add to what has been discussed so far?
Yeah, I mean, that was a comprehensive review. I'm just going to briefly touch upon the use of an EP catheter. So for all of those of you who may or may not be familiar with it, and whether you can see, this is a standard quadripolar catheter. You can see that it has platinum electrodes at the end, and they're not too dissimilar from a temporary pacing wire, probably a little bit softer. At this working end here, this is a non-deflectable catheter, but most EP catheters that you'd use with pacing would have a puller wire attachment here, which would allow you to deflect or extend this tip. And where this is particularly useful is when you may have difficulty cannulating the coronary sinus. Now, you do not need an EP system with this, but it gives you additional flexibility and torque ability to let you get into the coronary sinus. So if I can just show you my little heart model, I just want to check with you guys whether you can see things clearly. So the structure at the back.
Can you hold it a bit higher?
Yeah.
Thank you.
Right, let me get close to the screen. So this is going to be slightly challenging, but anyway, I'll put it in an AP position. So if you look at the coronary sinus in this model, it is posterior to the tricuspid valve, and that's quite important to understand, because as you go from the superior aspect, so you're coming from the left-hand side generally, the idea is to place your catheter first into the right ventricle. And with an EP catheter, if you have it connected to the mapping system, you'll be able to see predominantly right ventricular signals. So if any of you have joined on the foundation course, you might be aware of what we've discussed when we see these signals. And what the technique is, which Hasham has described, is a gentle pulling back and a counterclockwise rotation. So pulling back, counterclockwise rotation should get you into the os of the coronary sinus. Now, if there is a valve, it may get stuck, but in general, if you persevere a little bit, it will fly across. So because of the rigidity of this catheter and because of the fact that it can flex, the ones that are deflectable, it gives you this additional support and torqueability to get in. Now, these catheters generally pass through most guiding catheters. And so you would use essentially the telescoping technique of having the guide wire, guide catheter, and as you push the catheter across, the guide wire will then telescope into the structure. Now, one thing I just wanted to briefly explain on this model, because I think it can be useful to demonstrate, is what you see in the different views. So if you look at this as in PA, the coronary sinus sort of sits posterior in this angle. If you go RAO, the coronary sinus is posterior, and your coronary sinus view will appear upwards and backwards in this direction. So if you want to open it out, you go LAO, and then you see more of the coronary sinus. I don't know whether you can appreciate that. It's a little bit difficult to demonstrate, but that's LAO, and that's in RAO. So in RAO, the catheter is more vertical. In LAO, it sort of splits out it helps separate the coronary sinus. And both of them are useful to determine how lateral you go and how apical you go as well. So those are the little bits I wanted to add on from an EP perspective.
That's really, really useful. I just want to remind people that we have a chat box. If anybody has any questions, they're welcome to put them in. So far, this has been very instructive. Professor Mirvat, I don't know if you're online, but I know you tend to use the EP technology. Are there any tips and tricks you'd like to share? Able to see the screen at the moment?
Yep. It's sort of frozen, but
it's frozen. Excellent. I haven't started playing the venogram.
Okay.
So what I'm going to do is just walk through a little bit of what we've discussed. I think Dr. Hasham talked about getting venous access in a standard way, and we usually use a fluoroscopic approach if the patient's kidney function is satisfactorily. We use a needle, and you can see that when we do the venogram, we can see contrast. Are you able to see the moving images now?
Yeah.
Excellent. So, well, let's see what this case showed. I haven't actually pre-selected these. This is just a bunch of CRTs from the last few weeks that I'm sharing.
If you remind me at the end, I've just got one video to show. I can show it once you've done these cases.
Sure. So as Hasham has indicated, we use three separate access points, all simultaneously. And this is a patient in whom I've used a septal position for the right ventricular lead and a standard right atrial appendage position. What you can notice here, maybe you can make a comment about what you're seeing. This is an LAO view, Dr. Muzahir. What would you like to say about this particular image?
So your I don't know whether you use
Amplatz.
It's an Amplatz. Is that what
Yes.
you use routinely? But it's hooked in.
Go ahead.
I imagine that, I mean, it looks like the right atrium is enlarged so that the reach.
Very big, absolutely. So it's a very big right atrium.
Yeah.
Bearing in mind that this is in the LAO position, you'd expect the RV lead to be more to the left of the screen and coming towards you. When you see this, it's a clue that you haven't done enough rotation in your left anterior oblique angle. So that was one thing I wanted to demonstrate. And also, as you've mentioned, with an AL2 sitting in the right atrium, you still have, you haven't yet found your way into the coronary sinus. So there's a guide wire in the coronary sinus in the LAO position, and over the Amplatz catheter, we've managed to deliver a coronary sinus guiding sheath. And this is a venogram that I obtained from that particular patient. So I've frozen it over there. You can see on the right-hand side, can you see my pointer at all or not?
Yeah, you can see it, yeah.
You can see the target veins. They're usually in the lateral or posterolateral position, as Dr. Hasham's very clearly emphasized. And what I'm going to now do is show you the same image, but now in a PA position. PA is easier to work in. So you've got two branches there. You've got this relatively small branch and this very big branch. I'm going to ask Hasham which of these two branches he would aim for.
Yeah, so both have their own challenges. So the branch, the first branch, which is the smaller one, is actually looking quite small, and maybe the venogram, because it was an occlusion venogram, is not clearly showing us the size. But generally from this picture, it looks a bit small. On the other hand, the other vein is sizable and has a good reach. It goes all the way to the apex, but it has significant tortuosity. If you look carefully, it actually doesn't come out from under the vein. It comes out posteriorly and then takes 2 or 3 turns. But I think with the tools we have, I'd be confident we'd be able to get into that. So generally, I'd go for the second vein, just because I can get my lead a little bit more distally.
This is the same view in the LAO projection. So you'd go for the bigger vein, right?
Yeah.
I just wanted to point out here that although the bigger vein is a lateral vein, that the vein curves upwards and then comes, and the tributary sits in a posterolateral position. So this is actually a really good target vein. And I agree with you that this small vein is small. So if with a long vein like this and the opportunity to implant your lead at multiple spots within this tributary, you may be in a better position trying to use technology to get yourself in here. I'm not sure what we did. This is the other thing to note is that in that same vein, now that we've taken a more selective picture, a better picture, you can see the way these veins reconnect. Huh? So there's a vein, this vein, the large vein that you described, actually reconnects with the middle cardiac vein. So if for any reason you found yourself unable to get into this vein, you could always find the middle cardiac vein and follow it all the way right up towards this lateral position. So that's important to understand. This is an RAO view, so please don't misunderstand the anatomy. And as Hasham had indicated, this is the base of the heart. Here's the apex of the heart, and this is a mid position. One important thing to describe is that in general, we aim for a mid position because that's usually the part of latest delay in terms of the activation sequence of the heart. The other thing that I wanted to talk about is how to actually get the lead into the appropriate branch. So this is a doctor trying to get the lead into the earlier branch. The leads have two different delivery systems. The first one is a stylet-based, stylet-driven system, and the second one is a guide wire-driven system. Most of the time, I use a guide wire-driven system. I try and palpate the vein, just like Dr. Hasham demonstrated the palpation of the coronary sinus with a guide wire. Once you're in a branch vein, then you can palpate it with a guide wire, usually a hydrophilic guide wire that can form a little loop. And this is us trying to get it into the smaller branch. But as you can see, we changed track. We got into the smaller branch, but we couldn't get the lead into a very stable position distally. So we had to change our strategy. Please note that this is a bipolar lead. So the guide cath went up to the next available branch. And this is the beauty. Most people have two branches. And with the guide wire, I was able to find a more distal position and place it over here. One thing to understand is they talk about this thing called separation between the RV and the LV lead. This separation is not visible in this view. And the reason why it's not visible in this view, which is the PA view, is because it's not relevant in the PA view. It's only relevant in the LAO view. So you must only look for separation between the LV and the RV lead when you're looking at it in the LAO view. The reason why people talk about separation is that it's a surrogate for demonstrating that you've managed to get your lead into a posterolateral or a lateral position. That's very separate from the septal position of this particular lead. If you remember, Dr. Hasham demonstrated the coronary sinus works all the way around here, and there's an interior interventricular branch. In the LAO view, if you have your lead over here, there's no separation. I hope that's clear. This is the final position in the RAO view with a relatively apical position, but knowing that we had a bipolar lead, we're able to pace from the base, from the ring of this bipolar lead and get relatively good imaging parameters. I'll walk you through a couple more cases that really emphasize what has been discussed, but maybe Dr. Hasham or Muzahir, you may want to make a comment or two.
One thing I was going to say in terms of the guide delivery system, the Medtronic kit is quite soft. So it's a little bit easier to sort of negotiate tortuosities if you're going telescopically. The Abbott kit, for example, is a braided sheath, and that sometimes can hinder your progress into the coronary sinus. So you may have to think about using a sub-selector in that view.
Thank you. You can see the new venogram. There's a venogram here of the axillary vein. And as you can see, we've taken a venogram of the axillary vein. We do this as standard, and we do 3 separate punctures. And now I'm going to go straight to the coronary sinus cannulation. This is a technique that Dr. Hasham described. You push a Amplatz catheter. Again, it's a dilated ventricle. You push the Amplatz catheter anti-clockwise, and then you advance the wire. You palpate it with the wire. What's happening here? The wire isn't going past a particular point. What's going on there, Dr. Hasham?
It looks like it's encountered the valve there, Vieuxen's valve.
It's encountered a Vieuxen's valve. This is quite common. The way to negotiate this is either to change the wire to one that isn't so, that doesn't have such a J, to get the timing right when the valve is open, or to use the sub-select inner catheter, not the subcellular catheter, but the one that goes inside the subcellular catheter, which is straight, to try and atraumatically ease your way. you'll notice that as it meets the valve, there's some resistance. It's pushing it back. The guide cath is now being pushed backwards. So in order to negotiate this, I managed to get the Amplatz catheter a little bit higher, but you can see we're not really able to negotiate the valve there. It's still looping on it. So this is a guide cath going up as close to the valve as possible. And this is a venogram, but we can't really get beyond the venogram. We can't get beyond the valve, so we can't demonstrate anything. The only thing we can see probably is something ghosting here in the 5 o'clock position. So what I did was I took a balloon venogram, I inflated a balloon over here, and I took a bunch of pictures. And then as Hasham demonstrated, I then deflated it. I'm just going to pause it over here to demonstrate what's happening with a balloon venogram. The balloon is inflated. We can now put a good amount of positive flow. Remember the veins drain this way, yeah? So we have to occlude this and then push firmly in this direction, as long as you're not too aggressive. There are a few branches in this LAO position. There's this thing called an anterolateral branch, but it drains a relatively lateral position. And there's this thing here, which I think is probably a middle cardiac vein or an early lateral branch, which again drains the same position. You'll notice that very commonly the veins meet each other. So this is what we did, and it gave us a bit of a roadmap. You still need to get the equipment beyond that. And in order to do that, we use a subselection tool. In this case, I manipulated a guide wire down into the anterolateral branch and aimed for a relatively lateral position. I wanted to make sure that this was in the correct position. What you can see is a guide wire has gone and exploited the fact that the guide wire reconnects with the coronary sinus through this lateral lower branch. I don't know if you can see the guide wire clearly because it's clear to me, but I know it's very tiny. Can you see that, Hasham?
Yeah, we can. Yeah. You can see it now coming out from the coronary sinus nearly.
Yeah, it's out. It's basically in the body of the coronary sinus, and using that very deep-seated position, we're able to put this LV lead into a position. I think I saved this just for teaching purposes, and eventually that was our final position. I'll show you maybe two more. Lead sizing is important. You talked a little bit about lead sizing. I don't know about in different parts of Africa, but in Kenya, sometimes we get charged per lead, or the patient gets charged per lead. Again, just to remind you, we usually do a venogram. Everyone is allowed to do their own technique. In this case, I couldn't get the wire through. It took a while. Oh, I think we've shown this one. We've already done this one, so I'll come back to a different one. There are lots of CRT. Well, let me use a telescopic delivery catheter, the subselect catheter. Let me show one of those. So here we have the Amplatz sitting right in the mouth of the coronary sinus. And again, we've met another Wieson's valve. I'll let that play a third time. And there's a venogram, and you can see a lateral branch appearing very early. It's a little bit tortuous, but it's sitting over here. It's ghosting. There's another branch that comes below that probably is a middle cardiac vein, but an early branch of that middle cardiac vein is a lateral branch. And a lazy operator like myself would probably try and exploit that lateral branch, pull back on the guide cath. So here I pulled back on the guide cath to try and see if I could get it to just drop into that vein. And I couldn't. But in order to try and help me, I've used an inner catheter. You can see that there's a difference in shape between this catheter here, the tip here, and the tip there. This is the end of the guiding sheath, and inside that is a 90-degree subselection catheter. And now the subselection catheter has found its way into this branch, nice posterolateral branch. And we can take a venogram of that branch, and it looks like we can get the lead nicely embedded within there. Excuse the flashing lights. And that was the final position of the lead. Sorry about that. And any comments, Hasham?
No, I think you got away because there was some challenging anatomy ahead. You had a valve and you found a lateral branch, and so this was a good way to just get your subselect in and park it in a nice place.
Okay, so I've got something called CRT right-sided. So let me show that as a final picture. Every now and then, and in this particular case, the patient had a pacemaker infection. We have to implant the device on the left side, on the right side. It's a little bit more tricky, and all I'd say is that if you're going to do that from the right side, the technology is different if you want to do it efficiently and quickly. So through the right side, we've managed to get a guide wire into the right atrium, right ventricle. We've got the RA lead and the RV leads already in place. It's an ICD patient. And we've used, again, the same Amplatz technique to find our way into the coronary sinus. Again, we're in the coronary sinus and we've advanced the guide wire. The guiding sheath is not visible at the moment. It's somewhere up at the top. And that's all we could get. Because the guiding sheath was not a dedicated sheath, it was quite difficult to get everything through there. So the point I want to make is this is a soft wire. This is actually a Terumo wire that we've pushed into the coronary sinus. But the only thing I can get into the coronary sinus is this Amplatz catheter. If I had an EP catheter directing me in, it would have given me enough support, but this didn't give enough support for a left-sided guiding sheath to come through. So in order to negotiate that, I needed to exchange for a stiff wire. Stiff wires provide much more support. And that's what we ended up doing over here. We took the picture of the coronary sinus through the Amplatz catheter, not through the sheath, because the sheath ends over here. And we tried to interrogate the appropriate branch. This is a stiff wire now. It's called an extra stiff wire. You want to get one. And through that, I was able to now get my guide cath into the coronary sinus. Please note that the guide cath, look at the position of the guide cath. It's on the outer curve of the coronary sinus, just there. And if I was to push this guide cath, I could possibly disturb this, create a dissection. Dissections are tolerable usually, but they make it difficult for you to complete the procedure, and you have to bring the patient back another day, which isn't fun. So when you see that, you should always lead with a wire, which we did over here. And we found ourselves into in a small branch. Look at that. Look at the anatomy there. It's really weird, isn't it? But ultimately, in the LAO view, it found a relatively good option for lead placement, and that's where the lead was eventually placed. So I've demonstrated a few. We can continue this atlas. I just wanted to remind those of you attending that we have the Africa Heart Rhythm Association Congress in Kigali in September, and we'll be teaching the other elements of the technique that Dr. Hasham has described, how to split the sheath in that meeting, as well as there'll be some instruction during the Africa STEMI meeting happening in April, at the end of April in Nairobi. So there'll be opportunities for more hands-on exposure. I think Sharif, are you online? Maybe you can make some comments. Sharif is also an experienced implanter. As you do that, I'll have a look at the comments.
Hello, Jilan. This is Mirvat.
Hi, Mirvat. Hi, Mirvat.
Hi, a very nice case and very nice tips and tricks. Hello. Do you hear me?
Mirvat. Yes, we can hear you very clearly. Thank you so much.
Okay, I would like to ask you a question about this case. Is the position of the, if you have the choice of choosing between bipolar and quadripolar CS lead, in this case, choose?
So the question that's being asked is, would we use a bipolar or quadripolar lead? I think this case, if I'm not mistaken, is about 8 years old, and we didn't have access to quadripolar leads in Nairobi at the time. Quadripolar leads have some advantages and some disadvantages. The advantage of a quadripolar lead is the multiple vectors, and I think last week I talked specifically about when a quadripolar lead is particularly useful. You get up to 10 different pacing vectors to capture the left ventricle, and with a quadripolar lead, you can actually place the lead tip at an apical position, but pace from a more basal or mid position, which is physiologically more likely to resynchronize. However, the disadvantage of the quadripolar leads are two. Firstly, they come requiring a quadripolar system. You can't implant a quadripolar lead unless the device is quadripolar. And those, in Kenya at least, are more expensive. The other disadvantage is that they're slightly bigger. The smallest bipolar or pseudo-bipolar leads, they're called dual cathode leads, are smaller in the bipolar configuration than in a quadripolar. So we just have to be sure that the lead could be delivered if we were aiming to do a quadripolar. Let's just look at the vein again, since you mentioned it. This is quite a small vein. Having said that, it's probably big enough for a quadripolar lead, but I can't be sure. What I do know is that if I get the wire through this small branch, all the way around and back into the coronary sinus, I'll probably have enough support to deliver whichever lead I want. In general, quadripolar leads have significant advantages over bipolar leads. The only real difference is the price and the size of the bipolar leads that allow us to get into smaller spaces when the spaces are smaller. Thank you.
Another question, Mohammed Jilan. From the right side implantation of defibrillator, they recommend the dual coil ICD. Do you think it makes a difference when you, from your practice, if you are going to implant CRTD from the right side for any reason? Do you look for dual coil or just
so for those it's not
the defibrillator lead?
I'm sorry, Mirvat, I'm not sure if it's my connection or yours, but I'm not able to hear you. But what I've understood from your question is whether or not we should be using a single or dual coil lead in patients in general, and then specifically if it's a right-sided implant. So some machines allow you to pace.
That is the question.
Allow the ICD to shock from multiple vectors. You can shock from the SVC to the device, and you can shock from the from the RV coil to the SVC
coil.
You can shock from the RV coil to the device. And previously, it was only St. Jude who had that functionality. I believe there are more companies able to do that now. The advantage of a dual coil in a patient is that if you want to shock across the thorax and your RV lead isn't sat in a nice RV apical bed, then you may not create enough of a shocking vector if you're going from the right ventricle to the right can to successfully defibrillate. A few studies have looked at this in the era of defibrillation, what we used to call fibrillation testing, but was actually defibrillator safety margin testing. And in that era, there wasn't a major difference. It was about a 90% success rate, even with a single coil. What is the advantage of a single coil in a patient without obstructive airways disease and without severe obesity in the event that the patient's device becomes infected? And we'll be discussing infected devices later. It's a little bit easier to remove a single coil lead than it is to remove a dual coil lead. But I take your point that there are many operators who would recommend a dual coil lead if the device is right-sided. Nowadays, there's dedicated delivery system on the right side, coronary sinus implant. And I think that for this particular series is more important. I don't know what Muzahir would like to add to that question.
We pretty much implant single chamber devices, probably because of the experience with extraction and having to take out a dual coil lead is sometimes a bit more difficult because it sort of fibroses with the SVC. One of the things that we do occasionally is a defibrillation test. In patients, we put a right-sided device in because it gives you at least a degree of reassurance that the vectors that you've programmed will work. I mean, it's ultimately the question of whether you can deliver enough energy, and I think between where the right-sided device is placed and where the coil is similar to the anterior position that we place on the chest. So I don't think it makes a huge difference. As you know from previous studies as well, defibrillation testing doesn't very correlate very well with what happens in the real world. So it's something open to debate. But in general, as I said, we stick in single chamber devices. I don't know if I can show you this one video. This was a case that where we had a right-sided device. Can you see that?
Yes, we see it, Muzahir. Yes.
Yeah. So this was a particularly challenging case because this patient had an extraction, and they had atrial fibrillation, severe tricuspid regurgitation. And I want you to appreciate that here, where unfortunately the radiographers decided not to save any images, and we don't we only do fluorograbs. I hardly do any cines, but you can appreciate in this patient with a huge right atrium, the sort of reach that you need with a catheter to get into the RV, as well as getting into the coronary sinus. And if you look at the vector here between the ICD can and the RV lead here, I think you've got reasonable amount of myocardial sort of capture here. I didn't DFT this patient because it was a very, very difficult procedure because none of the standard guides actually reached the CS, and actually getting into the RV was challenging because you wanted to ideally get an apical position so that you could at least ensure there was decent capture, especially in a chap who was in complete heart block as well. So on occasion, you might encounter these patients who have got very, very dilated atria. They have severe TR, and then getting a lead can be very difficult. In particular, in this case, a venogram was done, but really nothing interesting could be seen. And one of the problems of putting a balloon catheter is that it prolapses everything out of the coronary sinus. So you've just about got in, and you put a catheter that brings out. And I think I got lucky at this point because I just passed a wire in and hoped for the best. And sometimes without seeing, you sort of blinded, you get into position. And on the final point, we mentioned you mentioned dissection. And for those of you who are starting in coronary sinus cannulation, just remember to treat the coronary sinus with a little bit of care and respect. Pushing in sheets, forcefully pushing in wires can disrupt the CS. In fact, my usual practice is to aspirate before I inject it to the coronary sinus, because if you are jammed in between the vessel and you then inject contrast, all you'll see is a dissection. So just bear in mind that when you think there's a valve, approach with care. Try to use sort of rotation movements rather than sort of forceful pushing. And especially if you're using super stiff wires, just be careful that you are remaining within the cardiac chamber and not dissecting or perforating.
No, that's important. Thanks. At some point, I'll share some horrible dissections and perforations. I think I presented some in Egypt before. There are a few questions in the chat box. We've got about 5 minutes, I think. So if anyone has any burning questions, please share them. I'm just going to make a few comments and invite Hasham to comment. The first one is comment from AJ's iPhone. It says lead electrode spacing is key too. When you see you'll be very apical, you may want a wider spacing, 60 millimeter LV lead tip over to ring over 47 millimeters. And again, if you don't have a lot of options, or the patient has already got it already implanted their device, to avoid phrenic stimulation, you could use a longer pulse width and a smaller amount of voltage in order to try and prevent the jump. So the phrenic nerve twitch there are two types of phrenic stimulation. The first one is stimulation of the diaphragm directly. And the second one is actually stimulation of the phrenic nerve, which is usually in the lateral lead position. And again, essentially, if you use a lot of energy, then it can jump through the vein and stimulate the phrenic nerve. If you use less energy, but a longer delivery of that energy, it may not jump across. So that's a good point. Hasham, did you want to talk about electrode spacing? And the other comment, which was shared by Dr. Mohsen Gabala, when would you choose bipolar or quadrupolar leads? Any comments on that, Hasham?
Yeah. So in terms of electrode spacing, I think it's just a matter of, as you said, trying to get resynchronization as much as possible. So on the LA view, your end result, try and separate the RV lead and LV lead as much as possible. And it is thought that this will give you the best option at stimulating both sides of the ventricle so that you achieve good resynchronization. I'm not very sure about the measurements and what is considered key, but a lot of the studies that I've looked at just tell us that the larger the spacing, the better. And I suppose if you're apical, then you want to increase the spacing, though. So that's probably a comment that we'll take. In terms of quadrupolar and bipolar, I think we touched on that a little bit. But with quadrupolar, essentially, you're having much more options for pacing. So with quadrupolar, you in case your leads are in a position that's not optimal, you still have four other leads, which now you can combine different vectors. So from all those four leads, you can have a multitude of vectors which you can now try and using, and that helps you. So if you're, for example, getting phrenic stimulation, you might find a lead that's or an option that's not giving you phrenic stimulation. On the other hand, in non-responders, later on, sometimes you can try other different polarities, and people who believe in co-optimization, you can look at which gives you the optimal cardiac output. But as you said, then sometimes they can become a bit bulkier, and you can't jam them into the very small branches. And in some patients who just have very small branches, that's a problem. Then expense on all part of the world, that's I think an issue. They're slightly more expensive than the bipolar leads.
Thanks for those comments. Sorry, Mohsin, did you want to talk did you want to raise a question, Dr. Gabala? Or was that a mis-
Hello, can you hear me?
Yes, very clearly. Thanks, Gabala.
Oh, okay. No, that was a good answer, but the problem is that you have to take the pic. So does everyone take the picture of the vein and do the target and then choose the quadripolar or bipolar after, or you go from the beginning? Because I had that problem before, that I choose quadripolar without even knowing anything about the patient. She was a young lady. And then there was the only vein had got very tight stenosis, pre-dilated with a lot of balloons, and it was not possible to deliver the quadripolar. So I thought that if I have a bipolar, it will be better. But the company just brought the pacemaker with quadripolar.
No, that's a good question. I think it's a challenge. Let me just respond to the stenosis. The best way to deal with the stenosis is a buddy wire. Predilation somehow doesn't seem to be as effective. A lot of the challenge is the rubbery nature of the lead, of the wire, sorry. And if you take 2 or 3 wires and then try and track it through that, it'll help. The other thing you can do is a stent. Not the best option, but it's an option that I've used once or twice before. In terms of what you should do, in best practice, you probably have both devices and types of leads on the shelf. If you're going to do a venogram and see what you're dealing with, if it's a patient who doesn't have coronary artery disease, in most cases, a bipolar lead will be satisfactory. Remember that we never used quadripolar leads for the first 20 years of CRT, or at least for the first 18 years of CRT. There were no quadripolar leads available. So we did everything using bipolar leads. And 97% of the time, it was satisfactory. So, we're talking about a small minority of patients in whom you're going to run into problems if you have, enough experience putting them in. But you're right, the smaller leads usually get to deeper positions. And then Muzahir is suggesting that if you just continue pushing, is what they call passive pushing. So you're pushing, but you're not sort of forcing it, then the vein will adapt. Good. Well, it's now 9:28. We a little bit over, but it's been a relatively good session. I congratulate Dr. Hasham on a really, really good presentation. And Muzahir, thank you for your additional insights. There don't appear to be any more questions in the chat box. We look forward to hosting you in a week's time. I don't have in front of me, but I can pull it up very quickly, the content for next week's conversation. Let me just have a look. What are we going to discuss next week? Sharif, can you remember? Okay, it says over here, CRT programming, the must-know basics. So this is a 30-minute talk. Dr. Brian Vasey has confirmed that he'll give it. So now we'll move away from the implant technique and we'll now talk about how to program the CRT device. So we'll go back to the technology and understand the best ways to program the device to get the best outcome from them. So I believe Sharif or Mirva, there's going to be a French group that joins shortly. So I won't
Yes.
end this talk. What I'll do is I'll just ask those of you who are not comfortable speaking French or who've received enough instruction, you're free to leave, and the rest of us who are leading the French talk, French conversation will stay online. Thank you all very much, and have a good evening.
Thank you very much, Gillian. And we wait for our French-speaking Morocco doctors.
Thank you, Dr. Jiren. Thank you, Dr. Mervat, Dr. Mudar, Dr. Hashim. Soon we'll start the French session now. ازيك يا مساء ازي حضرتك؟